Grab a drink and a snack and join us for discussions with the doctor on today's Be Well and Connect.
My name is Santiago Arafat. I am a colorectal surgeon here in Evansville, Indiana. We are with Tri-State Colorectal Group, and I've been here for almost 15 years. I chose colorectal surgery because I enjoy dealing with diseases of the gastrointestinal tract, and I enjoy being able to operate and help fix people that have bad things going on in their bellies. So that's a very simple way to explain it, but I also like to do endoscopy, which is a very important part of colorectal surgery, and I like to take care of patients with cancer. I've had second-degree relatives with cancer, not colon cancer, but cancer. But one of the things that happens when you're in practice here is you see a lot of people and you develop relationships with some of these patients, and inevitably some of them become your friends, and that's the truth. And probably some of the hardest things to deal with is when you take care of young patients with colon cancer who unfortunately have advanced stage, or older patients, and they don't do well. And so when the outcome is not what you want, then you feel that. I feel that. Colorectal cancer is a tumor or a growth or a neoplasm. There are many different ways we can define it, that tends to grow out of control, and when left unchecked can lead to problems such as anemia. It can invade other organs in the body and lead to organ dysfunction. Basically the way we treat it is, first and foremost, is prevention, right? We try to catch it before it becomes anything. But once it gets to a more advanced stage, whether it be locally or regionally throughout the body, we typically treat it with surgery, and we use a combination of chemotherapeutic agents if warranted. If you have a family member, particularly a first-degree relative with colon cancer, then that does double your risk in general for colon cancer. So you need to be screened. So you do need to speak to your family doctor to get checked out a bit sooner. If there's an established syndrome, such as HNPCC or Lynch syndrome or FAP, familial adenomatous polyposis, then you would need to be screened at a much younger age and screened more frequently. I do these surgeries weekly. I would say I take care of patients I see more colon cancer than rectal cancer, but unfortunately I see a lot of both. Collectively within our group we do hundreds a year. And personally I would say I share a large volume. So let's talk about the different treatments. There's surgical treatment, and then we can define post-surgical treatment or adjuvant treatment, or chemical treatment, so to speak, with chemotherapy. The advantages of doing surgery, obviously, you're eliminating the source of the problem, right? We're taking that physical cancer out, and hopefully reestablishing continuity or putting bowel back together so patients can continue to have a fairly normal quality of life from a gastrointestinal standpoint. Some of the drawbacks to surgery is it can be invasive, although we have newer techniques today to try to treat patients with a minimally invasive approach, right, with the famous laparoscopy and robotics, which patients benefit from greatly. But there are instances where sometimes GI function can be compromised just a little bit, where patients may have changes in bowel habits. There can be some absorption problems. And then, of course, there are issues where patients may end up with a colostomy or an ileostomy, which is, the bag, right? And there are many sort of problems that can come with that, but many benefits as well. From a medical standpoint, when patients have to deal with chemotherapy, surprisingly, chemotherapy for colon cancer, rectal cancer is pretty mild compared to treatment for other malignancies. But most folks tend to have subtle symptoms. They'll complain of neuropathy or sort of tingling in the fingers, maybe a change in taste. Sometimes they may feel a bit fatigued during the treatment. But surprisingly, and not surprisingly, the majority of patients do really well. Patients can have will go to work during chemotherapy. They can continue the normal daily activities during chemotherapy. Their hair's not going to fall out. They're not going to lose their eyebrows or any of that type of sequela that may happen with treatment for other types of cancers. So the first thing we do is we want to make sure you don't have disease anywhere else. That's most important, right? So we typically, once we have a biopsy-proven diagnosis, we've located where the tumor is, so we'd like to check some blood work. We want to make sure where your blood counts are. Are you anemic? Are you not anemic, etc. We like to look at your metabolic profile, meaning we like to look at your electrolytes, your sodium and potassium levels, see how your kidney function is. But more importantly, we look at your liver function. We want to make sure that the tumor has not spread out to other organs, particularly the liver. And then we will do some imaging. We like to get some CT scans of the chest, abdomen, and pelvis to ensure that we don't have anything in the pulmonary area and in the lungs, in the mediastinum. We want to make sure there's nothing spread out in the abdomen. Sometimes the cancer doctors or the oncologists who are phenomenal in treating these rectal cancer and colon cancer will do what's called a PET CT. Well, they will look for abnormal areas that may light up on these films to look for what we call extracolonic disease. So we don't give you pain medicine. There's no such thing. You just muscle your way through it, and that's how we're in it. No, okay. So things have changed. We now do what's called fast tracking, where we implement several steps and protocols to help facilitate an easy transition from hospital to home and to get you from hospital to home quicker, because we now know that people recover well at home. So most people who have surgery for colon cancer, rectal cancer, whether it be laparoscopic or robotic, go home in about 2 days, sometimes 3. We do know that the older you are, you need a little bit more TLC, so we'll keep you in the hospital for another day. If you have to have an open procedure, and studies have shown this, your length of stay is only extended by 1 day. We have many types of regimens to keep your pain well controlled. And the majority of patients that get surgery now have these, what we call tap blocks, which are localized injections in the musculature and the abdominal wall. And this helps tremendously with incisional discomfort. And these blocks typically last from 24 to 48 hours, so the patients are usually well covered. And then by the time these blocks were off, the patient's already sort of feeling better. And then we transition over to oral medication, and usually the oral medication is only taken for 5 days. So I think the post-operative process has gotten much better over the last couple of years. Yes, yes, and yes. I always tell patients when you have surgery for colon cancer, rectal cancer, whether it be a low stage or even a high stage, colon cancer, rectal cancer, we can still get you to a fairly normal, if not completely normal, quality of life. I have plenty of patients who do not have colostomies or ileostomies and are out there playing sports, they're dancing, they're doing all the things they want to do. And guess what? I have patients that have colostomies and ileostomies who are out there playing sports, dancing, swimming, and doing everything they want to do. So the limit that you have is really the limit you put on yourself. But we're here to help you to get back to your full potential, and most people do. Tough question. It depends. For colon cancer, really no. It won't affect your sex life negatively. So most people should have a fairly normal sex life, right? If you have to have surgery for rectal cancer, depending on the location of that tumor in the rectum, that may alter sexual function, simply because in order to effectively remove that tumor from the rectum, we sometimes have to work around or within nerves that do very important things. And sometimes those nerves, unfortunately, may get compromised. And that's just one of these things that sort of gets sacrificed in order to help patients live a meaningful life. From a surgical standpoint, if we have to take care of someone who has a low-lying or maybe a deep-seated rectal cancer, then there may be some difficulties in achieving pregnancy in women when we have to operate that low. But most of the times, it shouldn't be a problem. That depends greatly on the stage of the tumor. So typically we give rectal cancer, we treat rectal cancer with what we call upfront or neoadjuvant chemoradiation. And these are standardized treatments throughout the world based on very famous studies for tumors that will invade through the entire wall of the rectum, or if you have involved lymph nodes. Okay, and these are for low-stage tumors, low-lying tumors, typically within the pelvic cavity. And so the answer is yes, you will need chemotherapy and radiation for that. And the goal of chemoradiation is to several. It really is to downstage the tumor. So by downstage, we want to shrink that tumor down so that it makes surgery for us much easier, makes it easier for you. And the goal would be sometimes, and actually in many occasions, we can actually reconnect healthy bowel down to the rectum and avoid a colostomy. And we know that doing chemoradiation does help improve, diminish the chances of recurrence. So there are instances where patients have rectal cancer where they will not need chemotherapy or radiation. These are for what we call T1 or T2 tumors, and these are T stands for tumor depth of invasion, how far through the rectal wall these lesions are going in. And so if you have a small little tumor like a T1, sometimes we can treat that with a local excision. There are risks to that, and there certainly are things that we need to keep in mind when treating patients for that, especially for patients with T2. There are gold standard treatments that we have for that as well. But those are the instances where you would not need chemotherapy or radiation. So the first thing we do is we want to make sure you don't have disease anywhere else. That's most important, right? So we typically, once we have a biopsy-proven diagnosis, We've located where the tumor is. So would you like to check some blood work? We want to make sure where your blood counts are. Are you anemic? Are you not anemic, etc. We like to look at your metabolic profile, meaning we like to look at your electrolytes, your sodium and potassium levels, see how your kidney function is. But more importantly, we look at your liver function. We want to make sure that the tumor has not spread out to other organs, particularly the liver. And then we will do some imaging. We like to get some CT scans of the chest, abdomen, and pelvis to ensure that we don't have anything in the pulmonary area and in the lungs, mediastinum. We want to make sure there's nothing spread out in the abdomen. Sometimes the cancer doctors or the oncologists who are phenomenal in treating these rectal cancer and colon cancer will do what's called a PET CT. Well, they will look for abnormal areas that may light up on these films to look for what we call extracolonic disease. The stomal therapists we have here in town are phenomenal, and they are very good about not only locating the best spot for it, but also teaching you how to care for it and how to live a meaningful, functional, and productive life with the colostomy.
Thank you for joining Be Well and Connect, brought to you by Ascension St. Vincent.